So if you look at standard medical textbooks, human pelvic nerves are, they're mapped out like this perfectly clean electrical grid.
Right, like a neat little diagram.
Exactly.
Yeah.
You expect the main cables to just always run through the exact same walls. But inside the operating room for an intimate cosmetic procedure, surgeons are finding out that almost half of us are wired with just absolute unpredictable chaos.
It's completely wild when you actually look at the data.
It really is. So today we are looking at a medical landscape that completely shatters that illusion of the simple, effortless lunchtime lift that you always see advertised. We're going deep into the surprisingly intricate world of comfort management during labial puff treatments.
Also known as labia majora augmentation.
Right. And the sheer volume of science required to make this specific procedure painless is honestly staggering.
Yeah, well, we're dealing with a highly sensitive, incredibly vascular area of the body. So to understand how comfort is safely managed for you, we have to look past the marketing brochures and really dig into the actual clinical protocols.
And our sources for this deep dive are basically a heavy stack of compounding pharmacy guidelines, some dense pharmacological breakdowns, and these incredibly detailed anatomical studies mapping out pelvic nerve variations.
It's some pretty heavy reading.
Oh, yeah. But that is the mission today. We are going to uncover exactly how elite medical professionals navigate this complex anatomy to provide a completely painless experience for you, the patient.
Because, while aesthetic procedures are constantly sold as this quick refresh where they just apply a little cream and boom, make a quick adjustment.
Right. The reality is entirely different.
Exactly. The underlying science of making sure you don't feel a single thing is literally a masterclass in pharmacology and biological engineering.
Okay, let's unpack this. Because to understand how this begins, we have to look at how doctors start numbing the skin long before a needle ever even enters the room.
Right. So the first line of defense is always topical. But the sources are very clear that this isn't anything you can just pick up at a local drugstore.
No over-the-counter stuff here.
Not at all. Providers use highly specialized mixtures from compounding pharmacies. Most commonly, it's this strategic cocktail referred to as a BLT cream.
Which unfortunately has absolutely nothing to do with the sandwich.
I know, right? It would be a lot tastier if it did.
Yeah. But I noticed the breakdown of this in the pharmacy protocols. BLT stands for benzocaine, lidocaine, and tetracaine.
Correct.
But what I really want to understand is, well, why do they need 3 different drugs mixed together? I mean, if the goal is just to numb the skin, wouldn't a high concentration of just one of those do the trick?
You'd think so, but no, a single drug wouldn't cover the entire timeline of the procedure effectively. It actually all comes down to the molecular structure of each of those 3 anesthetics.
Oh, interesting.
Yeah, they basically create this pharmacological relay race. So benzocaine has a very tiny molecular structure. Because it's so small, it can slip right into the nerve's pain receptors almost immediately. It blocks the sodium channels in the nerve, so it can't send a pain signal to your brain. But because it's so small, it also washes out of the receptors really quickly.
Oh, I see. So benzocaine gives you instant relief the second the cream touches you, but it just doesn't last very long.
Precisely. And that's where the lidocaine comes in. It has a slightly larger, slightly more complex molecular structure.
So it takes longer to kick in.
Right. It takes a little longer to bind to those nerve receptors, providing intermediate depth and duration. Basically, it carries the baton.
Okay, so that's the middle leg of the race.
Yeah. And then finally, you have tetracaine. Now, tetracaine is a bulky, highly potent molecule. It takes much longer to take effect, but once it physically wedges itself into the nerve receptor, it is incredibly difficult for the body to dislodge it.
Wow. So it just camps out there.
Exactly. It provides a prolonged duration of profound numbness that lasts long after the actual procedure is finished.
Okay. The chemical relay race totally makes sense, but there's a mechanical issue here that I'm stuck on.
Right.
We're talking about human skin, right?
The stratum corneum.
Yeah, which is biologically designed to be this impenetrable barrier. I mean, it is literally meant to keep foreign substances out of your body.
It's very good at its job.
Right. So how can a cream simply sitting on top of that barrier possibly penetrate deep enough to numb tissue for an actual surgical procedure? Is it just like marinating a tough cut of meat where you just have to let it sit for 30 to 60 minutes? Or is there a trick to it?
Well, time is definitely a factor. Usually there is a 30 to 60-minute window of just letting it sit, but You're entirely correct about the skin being a formidable barrier.
That's tough.
It's like trying to push a thick gel through a solid brick wall. So to bypass this, modern cosmetic surgeons use this fascinating piece of technology alongside the cream called predictive permeation.
Predictive permeation.
Oh.
Or the sources also called it dermoelectroporation.
Right, dermoelectroporation.
I was reading about this in the clinical guidelines. It sounds incredibly intense, but the physics behind it are brilliant because it's not just rubbing the cream in harder, is it?
Oh, not at all. The doctor uses a specialized device for about 15 minutes over the exact area where the BLT cream was applied.
And it uses electricity.
Yeah, it delivers specific microelectrical pulses to the skin,
Yeah.
but these pulses don't shock you. Instead, they interact with the lipid bilayers, the fats that hold your skin cells together.
Okay, I'm following.
The voltage temporarily alters the structure of those lipids. It literally forces open microscopic water channels right in the skin.
That is wild. It's like temporarily shrinking the mortar in that brick wall so the medicine can just slip right through the gaps.
That is a perfect way to visualize it, yeah. It actively drives that complex BLT numbing cream much deeper into the tissue than it could ever go through just passive absorption.
So it turns a surface-level cream into a deep tissue prep.
Exactly. It dramatically improves the numbing effect.
Which means if you ever go in for a cosmetic procedure in a highly sensitive area and the provider just slaps on some generic cream and tries to rush you into the procedure room 5 minutes later,
Yeah, that's a red flag.
you now know they might be skipping crucial pharmacological and technological steps for your comfort.
Absolutely.
But flipping through these pharmacy protocols, I also realized there's a massive safety caveat here. They are incredibly strict about how this cream is applied. Like, you can't just bathe a patient in this stuff to make absolutely sure they are numb.
Oh, definitely not. The clinical protocols treat this cream with the exact same respect as an intravenous medication, and for really good reason.
Because it's so strong.
Yeah, these creams are compounded at such high, potent concentrations. Misusing them can be highly dangerous. The guidelines explicitly warn against applying these powerful creams over too large of a surface area or covering them up with plastic wrap.
Wait, covering them up?
Yeah, it's a practice known as occlusion.
Okay, because covering it traps the heat, right?
Mm-hmm.
And heat increases blood flow to the skin.
Yes. If you apply heat, or if you cover the area, the blood vessels at the surface of the skin dilate. They open up wide.
And that's bad because
Because when that happens, the body absorbs those potent anesthetics far too rapidly. It pulls them straight into the systemic bloodstream instead of keeping them localized in the skin tissue.
oh, wow, so it goes everywhere.
Right. And when high levels of lidocaine or tetracaine hit the central nervous system and the heart, it can lead to systemic toxicity.
Which sounds incredibly dangerous.
It is. It can cause irregular heartbeats, seizures, and severe respiratory issues.
Which is just a terrifying prospect for what is supposed to be a simple cosmetic enhancement. It really underscores why these procedures require absolute medical precision.
They really do.
But even with water channels pushed wide open by electroporation, a cream is only going to penetrate so far down.
Right. It has its limits.
So when the surgeon is actually placing volume deep into the tissue, whether they are restoring that volume using hyaluronic acid fillers or grafting your own purified fat, how do they bridge that final pain gap?
Well, that requires transitioning to an injectable local anesthetic. And just like the topical cream, the fluid they inject is a highly specific, highly calculated concoction.
What's in it?
Surgeons typically use a 50-50 mix of 1% lidocaine combined with marcaine, which is also known as bupivacaine. But the really crucial addition to this mixture is epinephrine.
Yeah, I noticed they mix epinephrine in, and I wanted to pull on that thread. My understanding is that epinephrine is basically adrenaline, right?
That's right.
It spikes your heart rate and aggressively constricts blood vessels.
Mm.
So I'm assuming they're utilizing that vessel constriction here so the numbing agent doesn't just bleed away into the rest of the body?
You've hit the exact mechanism. Epinephrine is vital here, specifically for its vasoconstriction properties.
Meaning it shrinks the vessels.
Right. By causing the local blood vessels to shrink and tighten, it accomplishes two incredibly important goals for the surgeon. First, it minimizes local bleeding.
Which makes sense.
Yeah, in aesthetic procedures, a clear visual field is everything. If the tissue is bruised or bleeding, the surgeon cannot see the natural contours to sculpt the labia accurately.
So it's about the final look, too.
Exactly. And second, as you deduced, by shrinking the blood vessels, it stops the body's circulatory system from washing the anesthetic away.
So it traps it.
It effectively locks the lidocaine and marcaine into that local pocket of tissue so the numbness lasts significantly longer.
Okay, that structural logic is sound.
Mm.
But I have to challenge the actual patient experience of this injection.
Okay, go ahead.
Because anyone who has ever sat in a dentist's chair and had a local anesthetic injected into their gums knows that the medicine itself burns terribly going in. The injection is often the most painful part of the whole visit.
That's very true.
So if the ultimate goal of this deep dive is understanding comfort, aren't they just introducing a sharp burning pain to stop future pain?
Well, the burning sensation is the traditional trade-off, yes. And what's fascinating here is that the reason it burns actually comes down to fundamental chemistry.
Chemistry. How so?
Local anesthetics are manufactured as acidic salts. They have to be formulated with a very low, highly acidic pH so that they remain stable on the shelf in the clinic and don't just degrade over time.
Okay, so they're acidic in the blood.
Right. However, the human body operates at a neutral pH of about 7.4. So when you inject an acidic solution directly into neutral human tissue, the local nerve endings react violently to that acid.
Oh, wow. So the body is literally sounding an alarm that an acid has just been introduced.
Yes. That reaction is the intense burning pain you feel. But elite surgeons utilize a chemical workaround to silence that alarm.
What do they do?
Savvy practitioners will buffer this acidic anesthetic mixture by adding sodium bicarbonate to the syringe right before they inject it.
Wait, sodium bicarbonate, like medical-grade baking soda.
Yes, exactly, a highly purified sodium bicarbonate. By mixing this alkaline solution into the syringe, it immediately neutralizes the acid of the anesthetic.
That is brilliant.
It really is. So when this newly buffered solution is injected, it matches the body's natural physiological pH. Because the acid is neutralized, the nerve endings don't react.
So no alarm.
Right. This simple addition significantly reduces and often entirely eliminates that terrible stinging sensation upon injection.
It is such a simple, elegant application of basic chemistry to completely transform the patient experience.
It makes a world of difference.
And looking at the sources, the physical administration of this buffered fluid is just as calculated. The texts detail the exact needle gauge and the exact placement.
Oh, the precision is key.
Yeah. They are using a 30-gauge needle, which is barely thicker than a human hair, and they're only injecting an incredibly small amount of fluid, usually just 4 to 6 cc's.
Yeah, that low volume is completely non-negotiable in aesthetic surgery. Precision is everything. I mean, if a provider pumps 20 cc's of numbing fluid into the labia, the tissue becomes completely distorted and engorged.
Right, it would just puff up with fluid.
Exactly. And then the surgeon loses the natural architecture of the anatomy. They wouldn't know where to place the filler or the fat graft to achieve a natural, balanced result.
That makes total sense.
So they keep the volume meticulously low and place it with extreme precision. Usually they inject it closer to the midline of the body, right near the crease between the inner and outer labia, and occasionally they place tiny amounts beneath the clitoral hood.
Wow. So they are essentially doing localized microscopic sculpting with the anesthesia itself before they even begin the aesthetic sculpting.
That's a great way to put it, yeah.
Which brings up a major question that stood out to me while going through these anatomical studies.
What's that?
Well, here's where it gets really interesting. If injecting the local superficial tissue is this meticulous and requires all this pH buffering and involves complex low-volume math, why not just bypass it entirely?
You mean?
Why not just target the main nerve that feeds the entire region and turn off the power at the source, like a fuse box?
Ah, you're referring to a pudendal nerve block.
Yes.
Well, the pudendal nerve is the primary electrical cable providing sensation to the perineum, the genitals, and the lower pelvic region.
Right, so logically you just numb that.
Theoretically, yes. A single, well-placed injection around the pudendal nerve would beautifully numb the entire area, eliminating the need for multiple local injections. But the cadaver studies and MRI data in our sources reveal exactly why this is wildly inconsistent in actual practice.
Yeah, the variation in the human body here is staggering. We're taught to view anatomy like a blueprint, right? You'd think human anatomy is like a standard blueprint where the wires are always in the same walls.
If only it were that simple.
But the sources show that when it comes to the pudendal nerve, the blueprint is basically absolute chaos, right? It's useless for nearly half the population.
Chaos is the clinical reality down there, yeah. The textbook definition, the one taught in early medical school, states that the pudendal nerve originates from the S2, S3, and S4 sacral roots right near the base of the spine.
Okay, so that's the standard model.
Right. But a combined anatomical analysis of over 500 human specimens showed that this classic pathway only occurs in about 54% of people.
Wait, really? So almost half the time, if a doctor relies purely on textbook landmarks, they're operating on completely wrong assumptions about where your nerves actually are.
Completely wrong. The nerve's formation is heavily dictated by embryonic development. As a fetus grows, nerves seek the path of least resistance through developing tissue, and that path varies wildly from person to person.
So it's basically making it up as it goes.
Kind of. Sometimes the pudendal nerve pulls fibers from the S1 root higher up. Sometimes it reaches all the way down to S5. And it gets vastly more complicated once the nerve actually forms.
How so?
Well, you'd expect one main table, right? The single nerve trunk traveling down the pelvis.
All right, like a thick power cord.
But the studies show that a single trunk only occurs in 47% of cases.
That is insane. So instead of one thick cable traveling neatly down your pelvis, the nerve splits early. It turns into 2, 3, or sometimes 4 tiny threads weaving their way south.
Yes, a double, triple, or quadruple trunk. And it doesn't just vary in how many branches it has. It varies in how it travels through the dense architecture of the pelvis.
The hypnotical course.
It really is. As this nerve exits the pelvic cavity, it has to cross between two major dense ligaments, the sacrospinous and sacrotuberous ligaments.
Okay.
The textbook says it should pass cleanly between them in a dedicated channel. But the sources document numerous cases where the nerve, or one of its many tiny branches, decides to literally pierce straight through the dense, fibrous tissue of the ligaments instead of going around them.
Oh my God. It's weaving like vines right through solid tissue where a surgeon's needle could never reliably reach it.
Exactly.
Which explains why blindly attempting to numb this nerve is such a massive roll of the dice.
Yeah, if a doctor attempts a blind pudendal nerve block, meaning they just feel for bone landmarks on your pelvis to guess where the nerve is, and then inject a large pool of anesthetic, hoping it soaks the nerve, they have a very high failure rate.
Because it could be anywhere.
Right. Your unique pudendal nerve might have 3 trunks, originate from completely different spinal roots, and be burrowing through a ligament 2 centimeters away from where their needle is.
This perfectly contextualizes why top-tier aesthetic surgeons rely on the local tissue injections instead. They just abandon the idea of guessing your internal wiring and focus entirely on numbing the exact tissue they're sculpting using those buffered low-volume injections we talked about.
Exactly. It is a brilliant adaptation to the reality of human biological diversity. It is the only way to guarantee consistent comfort during the active procedure.
Okay, so we've successfully navigated the procedure itself. The patient has had electrical pulses opening water channels to push a specialized BLT cream deep into the skin, followed by a pH-balanced, highly targeted local anesthetic.
They shouldn't be feeling a thing at this point.
Right. The actual placement of the volume is completely painless. But the real test of comfort management isn't just what happens on the surgical table, is it? What happens when the procedure's over and the patient goes home?
Managing the postoperative recovery is the final crucial piece of the comfort puzzle. For extended pain control, elite surgeons are increasingly turning to an advanced pharmaceutical technology called Exparel.
Exparel. Okay, the sources refer to Exparel as a liposome-coated bupivacaine. We know bupivacaine is the long-lasting numbing agent we talked about earlier. But how do the liposomes change the way it works in the body?
So think of a liposome as a microscopic, multi-layered lipid bubble.
Like a fat bubble.
Yeah, it's almost like a tiny onion made of fat cells. Exparel takes the active numbing medication and encapsulates it deep inside thousands of these microscopic bubbles.
Oh, wow.
The surgeon injects the specialized suspension right at the very end of the case. They wait until the end so that the added volume of the fluid doesn't distort the tissue while they are actively trying to sculpt the labia.
Right, preserving that visual field. And once it's in the tissue, how does it provide long-term relief?
Well, the body has to actively break down those lipid layers. As your body's natural metabolic processes slowly dissolve the outer layers of those microscopic bubbles, a small, steady amount of the numbing medication is released into the surrounding tissue.
Oh, so it's a time-release thing.
Exactly. This slow melting process provides the patient with up to 72 hours of continuous, localized pain control. It acts as a targeted internal pain pump that degrades naturally.
That mechanism completely changes the recovery landscape. I mean, it allows a patient to go home and avoid relying on heavy, systemic oral pain medications, which carry their own host of side effects.
Which is a huge benefit for the patient.
It really is. But as we wrap up this deep dive, we have to address the absolute limits of safety in this highly vascular area, because the marketing for cosmetic procedures relentlessly pushes phrases like minimally invasive and zero downtime.
Yeah, you hear that everywhere.
But reading the medical literature we have today, minimally invasive definitely does not mean zero risk, does it?
It absolutely does not. The most critical safety caveat in all of these sources centers on the vascularity of the vulva. The entire region is an incredibly rich, complex network of blood vessels.
Right.
And when a doctor is using a needle to inject a thick, viscous gel like a hyaluronic acid filler into a highly vascular area, the margin for error is incredibly thin.
So what is the mechanical breakdown of that worst case scenario? Like what actually happens if they make a mistake?
The primary danger is an intravascular injection. This occurs if the sharp tip of the injecting needle accidentally pierces the wall of a blood vessel.
Just pokes right through it.
Yeah. If the doctor doesn't realize they're inside a vessel and pushes the plunger, they inject that thick filler directly into the patient's bloodstream instead of the surrounding fat tissue.
Oh, no.
The filler acts as an immediate plug. It causes an arterial occlusion that blocks blood flow to the local tissue, and if that's left untreated, the local tissue dies.
But the sources noted it can be far worse than just local tissue damage, right?
Yes, if the filler enters a vein, it can travel through the vascular system. The medical literature documents a highly critical case where this exact scenario during a labia augmentation resulted in a hyaluronic acid pulmonary embolism.
A pulmonary embolism from a cosmetic procedure.
Yes, the thick filler traveled through the patient's venous system, passed through the heart, and lodged in an artery in the lungs, blocking pulmonary blood flow.
That is a life-threatening emergency stemming from an aesthetic office procedure. It fundamentally reframes how anyone should view these treatments.
Absolutely.
I mean, this isn't just a simple facial filler procedure being replicated further south. The vascular anatomy of the pelvis is incredibly complex and unforgiving.
Which is exactly why the medical literature constantly stresses the importance of provider selection. A highly qualified, board-certified specialist intimately understands this complex vascular anatomy.
They know exactly where the danger zones are.
Right. And they often use blunt-tipped cannulas instead of sharp needles because a blunt cannula will naturally slide around a blood vessel rather than piercing through it. They treat the anatomical risks with the utmost respect.
So what does this all mean for you listening right now? It is a powerful reality check on the true cost of aesthetic comfort and safety. To recap the incredible layers of science dedicated to this process, to provide a truly painless labial puff, modern medicine utilizes electroporation to force advanced three-part compounding creams deep through the skin barrier.
Right.
They bypass the wild, unpredictable chaos of the pudendal nerve by using highly precise baking soda-buffered local anesthetics that match the body's pH to eliminate burning.
Chemistry at work.
They finish with slow-release, microscopic lipid bubbles for days of post-op comfort. And they do it all while meticulously navigating a microscopic minefield of blood vessels using blunt instruments.
It is a profound application of pharmacology, physics, and anatomical expertise to achieve what looks, to the patient, like a simple, effortless result.
Which leaves us with a final thought to mull over. Considering how wildly unpredictable the pudendal nerve is from person to person with its multiple trunks, varied origins, and ligament-piercing tendencies,
Right.
how long will it be before routine, real-time 3D nerve mapping or genetic anatomical profiling becomes a standard part of our pre-op check-in.
That would change everything.
Imagine a near future where a quick, non-invasive scan perfectly maps your unique internal wiring before a doctor ever touches a needle, completely eliminating the guesswork from anesthesia forever. Thank you for joining us on this deep dive. Keep asking questions, keep looking past the marketing, and always demand the absolute highest standard of care in your own health journey. Until next time.